Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing the questions and answer key to the series of ventilator videos that we have already uploaded. So, volume control ventilation delivers a predetermined dash to the patient using variable dash according to the changing compliance and resistance. So the answer is volume control ventilation delivers a predetermined tidal volume to the patient using variable peak inspiratory pressure according to the changing compliance and resistance. So, as we have already discussed, volume control ventilation, the volume is controlled. That is, the tidal volume delivered will be like set by the operator, and the pressure will be varying. So, coming to the second question, during pressure control ventilation, an increase of airway resistance or a decrease of compliance would. So the options are reduce delivered volume, raise the peak inspiratory pressure, reduce the work of breathing, and cause respiratory alkalosis. So the answer is during pressure control ventilation, an increase of airway resistance or a decrease of compliance would reduce the delivered volume. So as already known, pressure control ventilation, we'll be setting a pressure. So the based on the pressure, the tidal volume delivered will be varying. Coming to the third question, the PEEP is most commonly used to correct. So the options are hypercapnia, mild hypoxemia, refractory hypoxemia, and respiratory acidosis. So the answer is refractory hypoxemia. So PEEP is mostly used in the management of hypoxia, and it is of most use in the management of refractory hypoxemia. The fourth question, dash is a mode in which the ventilator delivers controlled or mandatory breaths and allows the patient to breathe spontaneously between the mandatory breaths. So the options are intermittent mandatory ventilation, continuous positive airway pressure, mandatory minute ventilation, and airway pressure release ventilation. So the answer is intermittent mandatory ventilation. So intermittent mandatory ventilation, there will be ventilator driven breaths or mandatory breaths, and in between, if the patient is spontaneously triggering breath and adequate tidal volume is reached, there will be intermittent patient triggered breaths also. So it is an intermittent mandatory ventilation, that it has both ventilator triggered and patient triggered breaths. Coming to the fifth question. Dash is primarily used to reduce the work of breathing imposed by the endotracheal tube and ventilator circuit during spontaneous breathing. The options are pressure support ventilation, pressure control ventilation, airway pressure release ventilation, and continuous positive airway pressure. So the answer is pressure support ventilation. So in pressure support ventilation, basically it is a spontaneous mode of ventilation and all the breaths are patient triggered, and the pressure support provided will help to overcome the resistance and all that is provided by the ET tube and the ventilator circuit. Coming to the sixth question. Which of the following is not an indication for mechanical ventilation? The options are acute ventilatory failure, impending ventilatory failure, severe hypoxemia, and airway obstruction. So as you all know, acute ventilatory failure, impending ventilatory failure, and severe hypoxemia are indications for mechanical ventilation, and the answer is airway obstruction. Coming to seventh question, the primary purpose of prophylactic mechanical ventilation include all of the following except. Options are to minimize the risk of pulmonary complication, to reduce prolonged hypoxia of major body organs, to reduce the work of cardiopulmonary system, and to monitor the arterial blood gases and vital signs. So the answer is D, to monitor the arterial blood gases and vital signs. Eighth question, PEEP may be indicated in patients with decreased dash and presence of dash. So the options are tidal volume in chronic hypercapnia, B, functional residual capacity in refractory hypoxemia, C, vital capacity in acute hypercapnia, D, tidal volume and refractory hypoxemia. So the answer is functional residual capacity and refractory hypoxemia. So PEEP is basically always used in the management of hypoxia, and it is not used in the correction of hypercapnia. It is used in the management of hypoxemia. The ninth question, if the desired IE ratio is 1:3, what should be the I time percentage? So IE ratio 1:3. That means if it is like 4 parts are there, first one part will be for inspiration and the remaining 3 parts will be for expiration. So while we are expressing it as a percentage, 25% of time will be for the inspiration and the remaining 75% will be for expiration. Or example, if the total time for a respiratory cycle is 4 seconds, 1 second will be for the inspiration and remaining 3 seconds will be for the expiration if we are setting the IE ratio as 1:3. 10th question, the dash and dash are two alarms that are used to detect the circuit disconnection. So the options are A, low pressure, high pressure, B, high PEEP, high volume, C, low volume, low PEEP, and D, low pressure, low volume. So the answer is a low pressure and low volume alarms. Coming to the 11th question, which of the following is not a common potential complication of positive pressure ventilation? So the options are hypertension, decrease in cardiac output, accidental patient disconnection, and barotrauma. So as you all know, the answer is hypertension. So the common complications associated with positive pressure ventilation, it is hypotension and not hypertension. So the answer here is hypertension. Hypertension is not a complication of positive pressure ventilation, but there can be reduced cardiac output due to like reduced in intrathoracic pressure, then the accidental patient disconnection can happen, and there can be barotrauma due to the positive pressure we are providing. 12th question, the area enclosed under the expiratory flow waveform should dash the area under the inspiratory flow waveform. If the expiratory volume is less than the inspiratory volume, dash may be present. So the area enclosed under the expiratory flow waveform should be equal to the area under the inspiratory flow waveform. And if the expiratory volume is less than the inspiratory volume, there will be circuit leak or gas trapping present. 13th question. In the pressure support ventilation, only the dash level is set, and under normal condition, dash are and under the normal condition, dash are primarily under the patient's control. So, in pressure support ventilation, basically, the pressure support level is set by the operator. And under normal condition, the flow, volume, and inspiratory time are primarily under the patient's control. So, pressure support ventilation is a spontaneous mode of ventilation where all the breaths are patient triggered, and only will be providing a pressure support to overcome the resistance provided by the ET tube and the ventilator circuit. The flow, the volume, inspiratory time all are based on the patient's trigger and patient breathing. 14th question. On a flow waveform, failure of the expiratory flow to return to the baseline is indicative of dash, and this condition may lead to dash and possibly autopsy. So, on a flow waveform, failure of the expiratory flow to return to baseline is indicative of incomplete expiration, and it can lead to gas trapping and possibly autopsy. 15th question. In the presence of excessive airway resistance, the expiratory flow is dash and the expiratory time is dash. So, if there is an excessive airway resistance, the expiratory flow is decreased and the expiratory time is prolonged. That is, if there is a resistance to your airway, the expiration, like the rate of expiration or the flow of expiration will be reduced because there is a resistance there. And as a result, the time taken for the entire breath to be delivered or the expiration to happen will be hence prolonged. So there will be resistance, so it will take a longer time for the expiration to be completed. So as a result, the expiratory flow will be reduced and the expiratory time will be prolonged. Coming to the 16th question, the failure of the expiratory flow to return to the zero baseline is indicative of. So, as already discussed earlier in an earlier question, when the expiratory flow is not coming back to the zero baseline, it indicates that Either there is a gas leak or a circuit leak, and some air has been leaked through the circuit disconnection or a circuit leak, or otherwise some air is being trapped within the patient's respiratory system or the alveoli and all, and as a result the complete flow or the complete volume of air that has been given in during inspiration is hence not received. So it may be because of a circuit leak or a gas leak, or it may be because of a air trapping, that is trapping of air within the patient's alveoli. And if at all air trapping is building up, it can further lead to another complication known as a auto PEEP. So failure of the expiratory flow to return to the zero baseline is indicative of gas leak or air trapping. 17th question. To wash out carbon dioxide, the parameters adjusted are. So the options are A, FiO2 and respiratory rates, B, tidal volume, respiratory rates in PEEP, C is respiratory rates, PEEP and FiO2, and D is tidal volume and respiratory rates. So anything related to carbon dioxide washout is the tidal volume and the respiratory rates. FiO2 and PEEP has nothing to do with the carbon dioxide washout. It basically deals with the oxygenation. So carbon dioxide washout is pertaining to the ventilation part, and it is depending on tidal volume and the respiratory rates or even the IE ratio. But the FiO2 and PEEP are parameters that determines the oxygenation or the correction of hypoxia. So here the answer is tidal volume and respiratory rate. 18th question. To improve the oxygenation, the following parameters are adjusted. So the options are FiO2 and respiratory rate, PEEP and FiO2, respiratory rate, PEEP and FiO2, tidal volume and respiratory rate. So the answer is PEEP and FiO2. 19th question. If in a patient, frequency sets is 15 breaths per minute and the IE ratio is 1:3, the time to be set is. So it questions the patient frequency set is 15 breaths per minute. So like for each breath there will be like 4 seconds, because there are 60 seconds in a minute and there are 15 breaths happening. So each breath will be like 4 seconds. 60 by 15, that is 4 seconds. And the IE ratio is 1:3. That is 4 seconds will be each breath. So 1 second will be for inspiration and 3 seconds will be for expiration. So the I time to be set is 1 second. Coming to the 20th question. So we have a graph there. It is a pressure time scalar. And the question is, you can see there are like A and B, two graphs are there. So identify the dysynchrony and the corrective measure take. So here the dysynchrony is with the cycle. It is a cycle dysynchrony, and what we can do is that we can decrease the inspiratory time to overcome the cycle dysynchrony. So there are basically flow dysynchrony is there, cycle dysynchrony is there, and trigger dysynchrony is there. And here it is a cycle dysynchrony, and the corrective measure that can be taken to overcome this is to reduce the inspiratory time. So coming to the 21st question. So it is again a pressure time scalar is there. So here the graph 1 represents the baseline graph. So there you can see a peak inspiratory pressure and peak plateau is there, and that is the normal baseline graph. And in the second graph there is a increase in peak inspiratory pressure, and the P plateau is static. The P plateau is, there is no change in P plateau. Only the peak inspiratory pressure has increased. So, as a result, the static P plateau with the increased peak inspiratory pressure, the difference between the peak inspiratory pressure and the P plateau is also increased. So, coming to the third graph, there is an increased peak inspiratory pressure and also there is an increase in the P plateau. Since both the peak inspiratory pressure and P plateau has increased, like with the same increase is there, the difference between peak inspiratory pressure and P plateau is unchanged in the third graph. So the second graph is basically showing an increased airway resistance. Due to increased airway resistance, the peak inspiratory pressure will be increased, but the P plateau will be static. And the third graph is showing a decreased compliance, and because of a decreased compliance, both the peak inspiratory pressure and the PEEP plateau are increased. So as a result, the difference between the peak inspiratory pressure and PEEP plateau will be unchanged, but both PIP and the PEEP plateau will be increased. So the second graph is corresponding to increased airway resistance, third graph is corresponding to decreased compliance. Coming to the 22nd question. The procedures done to assess auto PEEP and plateau pressure. So the options are ends inspiratory hold and expiratory hold, the expiratory hold and inspiratory hold, pre-inspiratory and pre-expiratory hold, and recruitment and inspiratory hold. So the answer is to know the or to assess the auto PEEP, we'll have to do expiratory hold, and to assess the plateau pressure, we'll have to do the inspiratory hold. These are like procedures that are being done in the ventilator to assess the auto PEEP and the plateau pressure. Coming to the 23rd question. In ARDS ventilation, the plateau pressure is targeted below options are 50 centimeter of water, 45 centimeter of water, 30 centimeter of water, and 20 centimeter of water. So the answer is 30 centimeters of water. This is like following the ARDS net protocol. So we will be assessing the plateau pressure every 4th hourly, and we will be targeting a plateau pressure of less than 30 centimeter of water. So if the plateau pressure is getting altered, we will control the pressures and all accordingly. So coming to the next question, the 24th question. Driving pressure in ARDS ventilation equals. So the answer is difference of P plateau and P. So driving pressure is the difference of the P plateau and the P. The 25th question. The dotted graph and bold graph represent. So here you can see a flow volume loop is there, and in that in the expiratory limb, you can see a dotted graph and then a bold graph. So the dotted graph is representing decreased peak expiratory flow rate that is arising due to increased airway resistance. So basically, you can see this type of conditions like in asthma and all, where there will be some increased airway resistance due to bronchospasm, and hence the expiration will be limited, or the peak expiratory flow will be reduced due to increased airway resistance. So to overcome the airway resistance, we'll provide with bronchodilator, nebulizations and all, and to overcome the bronchospasm. So as a result, the expiratory flow will be improved, and that is depicted by the bold graph. So here it is a decreased peak expiratory flow rate, which is improving with the bronchodilator, that is depicted by the dotted graph and the bold graph. The 26th question. Airway resistance may be increased in all of the following clinical conditions except A. Airway obstruction, B. Endotracheal tube with small internal diameter, C. Condensation into the ventilator circuit, and D. Tachycardia. So the answer is tachycardia, because like tachycardia has nothing to do with the airway resistance. The other things are related with the airway and the ventilator circuit, which hampers the airway, or it will lead to increased airway resistance. 27th question. The slope of a pressure volume loop is shifted towards the pressure axis. This condition is consistent with increase in compliance, increase in conductance, decrease in compliance, and decrease in airflow. So the slope of a pressure volume loop, if it is shifted towards the pressure axis, it is depicting a decrease in compliance. 28th question. The most recent blood gas report shows that the patient is hypoventilating. The PaCO2 is more than 65 millimeters of mercury. The physician asks the therapist to improve the patient's alveolar ventilation by making changes to the ventilator settings. So the therapist should A. Decrease the tidal volume. B. Increase the mechanical dissipates on the ventilator circuit. C. Increase the frequency. D. Increase the FiO2. So from this we know that patient is hypoventilating. PaCO2 is more than 65. So what we want is to improve the ventilation. To improve the ventilation, we'll have to improve the minute ventilation. That is, minute ventilation is the product of the tidal volume and the respiratory rate. So we can either increase the tidal volume or increase the frequency. And also we can reduce the mechanical dead space on the ventilator circuit. So here the answer is we can increase the frequency. The other options, decrease the tidal volume, is wrong because we have to increase the tidal volume. Then increase the mechanical dead space of the ventilator circuit is wrong because we'll have to always reduce the mechanical dead space. Then increase the FiO2 has nothing to do with ventilation. It only improves the oxygenation. So the answer is increase the frequency. 29 question. Hypoventilation is characterized by. So as in the previous question, we know that when a patient is hypoventilating, the carbon dioxide won't be given out. So there will be an increase in the PaCO2. And the increase in PaCO2 will further leads to a respiratory acidosis, which will be a decrease in the pH. So here the answer is increased PaCO2, and it is not an increase in PaO2 or increase in pH. It will be increased PaCO2 with a decrease in the pH. So here the answer is increase in PaCO2. 30th question. Ventilation-perfusion mismatch is common in lung diseases. For example, a low ventilation-perfusion ratio may be seen in dash and a high ventilation-perfusion ratio in dash. So, a low ventilation-perfusion ratio may be because of a reduced ventilation with or because of the increased perfusion. So it will be mostly because of a reduced ventilation that is seen in atelectasis. And a high ventilation perfusion ratio will be because of a like either a normal ventilation with the reduced perfusion or an increase in ventilation. So it is mostly seen in condition with a normal ventilation, but the perfusion will be reduced. As a result, the VQ ratio will be high. So that is seen in conditions like pulmonary embolism where the perfusion is impaired. So low ventilation perfusion will be seen in atelectasis and high ventilation perfusion will be seen in pulmonary embolism. 31st question. When the ventilator assumes all of the ventilatory work, it is termed as. So that is all the breaths are provided by the ventilator, then it is a full ventilatory support. Next question. In volume control ventilation, the peak inspiratory pressure increases when the patient's, the options are compliance or airway resistance is increased, B, compliance or airway resistance is decreased, C, compliance is increased, airway resistance is decreased, and D, compliance is decreased and airway resistance is increased. So, as you all know, in volume control ventilation, the volume will be fixed by the operator and the peak inspiratory pressure will be varied according to the patient's airway resistance, the compliance and all. So when there is a fixed volume and when the patient's airway resistance is increased or the patient's compliance is decreased, the peak inspiratory pressure will be high. So the PIP is like increasing with increased airway resistance and with the decreased compliance. Next question. A mode of ventilation that augments a patient's spontaneous tidal volume with a preset level of pressure is called pressure support. So, a mode of ventilation that augments a patient's spontaneous tidal volume with a preset level of pressure is a pressure support. So, in pressure support, we will be providing only the pressure support and all the breaths will be the patient-triggered spontaneous breaths. 34th question. Impending ventilator failure may be evaluated by trending a patient's. So the options are respiratory parameters in mechanics, the arterial PO2, the vital signs, and hemodynamic parameters. So the answer is respiratory parameters and the mechanics. Next question. Minute ventilation is equal to. I have already discussed it is the product of tidal volume and the respiratory rate. Next question. The ideal body weight in males is equal to. So this ideal body weight calculation is basically of very importance in ARDS ventilation. So how to calculate ideal body weight is for males it is 50 kg plus 2.3 into height in inches minus 60. And similarly coming to the next question, it is the females, the ideal body weight is equal to 45.5 kg plus 2.3 into height in inches minus 60. So these are the formulas for deriving the ideal body weight. Coming to the next question. The physician asks a therapist to evaluate the following ventilatory parameters for a possible weaning attempt. And the therapist should report to the physician that the only parameter that suggests a successful weaning is. So the options are spontaneous frequency of 40 per minute, spontaneous tidal volume of 7 ml per kg, minutes ventilation of 16 liter, and a PaCO2 of 55 millimeters of mercury. So basically, if we are weaning a patient, if the patient is getting a spontaneous tidal volume of 7 ml per kg, we can wean the patient. But if the patient's frequency is of like 40 per minute, the patient is tachypneic. If the minutes ventilation is 16 liter, it means maybe because of like a increased frequency, the patient will be having increased ventilation. And PaCO to 55 means the patient is not adequately ventilating. There is some carbon dioxide buildup. So there are like these are the ventilation criteria or the weaning criteria for weaning a patient from ventilator. So basically, if the patient's spontaneous tidal volume is of 7 ml per kg, we can wean the patient from the ventilator. Next question. A patient has an average spontaneous frequency of 20 per minute and tidal volume of 400 ml. What is the calculated RSBI? So RSBI is a rapid shallow breathing index, and so here it is like 400 ml and 20 per minute. So the answer is 50 breaths per minute per liter. So basically it is a like a ratio of the frequency by the tidal volume in liter. So that is it will be 20 divided by 400 by 1000, that is 20 into 1000 by 400, which is coming to 50. So it is the ratio of frequency or the respiratory rate divided by tidal volume in liters. So here it will be 20 divided by 0.4 liters, that is 50 breaths per minute per liter. So coming to next question, for a successful weaning outcome, a spontaneous breathing patient should have a calculated RSBI of, so the options are more than 100 breaths per minute per liter, less than 100 breaths per minute per liter, between 100 to 200, and between 200 to 400. So the answer is less than 100 breaths per minute per liter. So the target RSBI for a successful weaning in a spontaneous breathing patient should be less than 100 breaths per minute per liter. Partial ventilator support via DASH is done by reducing the ventilator frequency gradually. So the options are SIMV, T-tube, spontaneous breathing trial, and pressure support ventilation. So it is a SIMV. So it is like SIMV mode. There will be like some, if the patient is not like taking adequate trigger, the ventilator will provide intermittent mandatory ventilation. So there it is a synchronized mode of both patient triggered and ventilator triggered breath. Next question. All of the following trends may be used as indicators of weaning failure with the exception of, so options are increasing tidal volume, B increasing PaCO2, C decreasing PaO2, and D decreasing static compliance. So if the patient is having an increasing PaCO2, we know the ventilation is impaired. So we can't wean the patient, or like if we are going for weaning, it will end up in a weaning failure. Decreasing PaO2, the patient will be going to hypoxia, so it can go for a weaning failure. Decreasing static compliance, if the patient's compliance is reduced, there will be increased resistance and other failure issues may come up. Increasing tidal volume, so if the patient's tidal volume is improving, we know that we can wean the patient. So as indicators of weaning, like failure will be B, C, and D, and increasing tidal volume indicates that it is not going to a failure. We can wean the patient. So the which one is not an indicator of weaning failure is increasing tidal volume. And the other three are indicators of weaning failure. Next is, what is RSBI in weaning? So it is a rapid shallow breathing index. So, and how to calculate RSBI? Already discussed, it is the ratio of respiratory rate or frequency and tidal volume in liters, and it is expressed as breaths per minute per liter. Next question. Permissive hypercapnia is a technique in which the mechanical dash is reduced, and this change is done intentionally to increase a patient's dash. Permissive hypercapnia is basically a technique in which the mechanical tidal volume is reduced, and this change is done intentionally to increase the patient's PaCO2. A patient's low pressure alarm is triggered persistently. The likely cause of this condition include all the following except disconnection of ventilation circuit, kinking of the ET tube, power failure, leakage of endotracheal tube cuff. So the answer is kinking of ET tube. Kinking of ET tube, there will be increased pressure in the circuit and there will be a high pressure alarm. So the low pressure alarm will be triggered if there is a ventilator circuit disconnection, any leak is there, circuit leak is there, or ET tube cuff leak, anything is there. And kinking of ET tube will not trigger a low pressure alarm. Coming to the next question. During patient rounds in the ICU, the high pressure alarm of ventilator is triggered. This condition is likely caused by, the options are disconnection of ventilator circuit, low pressure limit set is too high, loose ventilator humidifier fitting, and patient coughing. The answer is patient coughing. When the patient coughs, there will be an increase in the airway or the ventilator circuit pressure, and it will lead to a high pressure alarm. But if it is a disconnection or a loose ventilator settings, it will be a low pressure alarm that will be being triggered. In volume, pressure and flow waveforms, the time in second is displayed along the horizontal axis or the x-axis. So the x-axis is the horizontal axis and the time will be on the horizontal axis, and the pressure, volume or the flow waveforms will be along the y-axis or the vertical axis. The 49th question. Tidal volume can be calculated or determined by measuring the dash under a dash waveform. So the options are slope of a flow time, slope of a pressure time, area of a flow time, or area of a pressure time waveforms. So the answer is the flow time. In the flow time waveform, the area under the graph will depict the tidal volume. So the flow, it is basically giving a product of the flow and the time. So area under a flow time graph will depict the tidal volume. The last question. In pressure control ventilation, the dash is typically set by the operator. So the options are rates and I ratio, pressure level and I ratio, pressure level and rate, pressure level, rate and the I ratio. So in a pressure control ventilation, we will be presetting a pressure. It is a mandatory ventilation, so the rate will be set by the operator. The I ratio will also be set by the operator, and the tidal volume delivered will be different based on the patient and the ventilator's dynamics and the mechanics. So in a pressure control ventilation, the pressure level, the rate and I ratio are set by the operator, and the pressure and the volume delivered will vary from breath to breath. So these are the questions and answers that has been asked in our ventilator MCQ that was based on our series of videos of ventilator. Thank you.